All right, I think we've got a lot of people, so let's just jump in here. Hello, everyone. Thank you so much for joining us today for the Texas Covered panel titled Fulfilling the Promise of Telemedicine, What's Next? I think that is an ambitious and exciting title for the conversation today. So we're really excited to talk through the opportunities and barriers for telehealth and telemedicine as we have really good speakers lined up here for today. So wanted to take a minute to introduce everyone, and then we will jump right in. So my name is Natalie Trebes. I lead health plan research for the advisory board, which serves a variety of different healthcare organizations across the nation. I work with a number of different types of health plans, and they are all very focused on this very question. So I'm excited to facilitate the conversation today. Joining me are all of the experts here. I've got Dr. Patrick Vinck, who's the medical director with PopHealthCare, Cari, who's the vice president of government affairs with Quest Analytics, and Michael Farrell, who's the chief revenue officer with MDLIVE. Before we get started with the conversation, just want to make sure everyone knows you can ask questions into the question box, and I will be monitoring those. You can also put comments and questions in the chat box as well, and we'll be looking at all of that. So really coming at you in a multimodal fashion, fitting with the theme here. To get started, I just want to give everyone a minute to share a little bit about yourself, your organization, and let's go with what's the most surprising or interesting thing that you've learned about telehealth adoption over the course of the pandemic so far. So Patrick, we'll start with you.
Awesome, thank you so much. Good morning, everybody. My name is Dr. Patrick Vinck. I'm the medical director with PopHealthCare. My background is in primary care, really serving high-risk patients in the primary care setting. At PopHealthCare, we deliver primary care to patients' homes throughout Arizona and Texas, Florida, New York, and some other locations as well. I think telehealth is always kind of been a part of my practice, and I think it's a great way to augment and support care. And I think we all know that healthcare really changes in a slow but deliberate way, and it takes big catalysts like we've had recently to make important changes where we can leverage and begin to utilize the technology to really serve patients in a more efficient fashion. So I think that's the most exciting part of the telehealth transformation I'm seeing.
Awesome. Cari, go over to you.
Thanks, Natalie. So I'm Cari Lee. I'm a former insurance regulator, and now I'm the VP of Government Affairs at Quest Analytics. So I'm always looking at all of this through the regulatory lens. And many of you probably know our company because you use us to file your network adequacy requirements at the TDI, or also with the Texas Medicaid Department, or maybe it's likely that you use us for Medicare Advantage network adequacy, because we're the tool that CMS uses to measure network adequacy. And they're also interested in looking at the accuracy of provider directory data, and we're looking forward to helping them with that. But I would say that, one of the things I've heard throughout the day is like, okay, so we have COVID and it's changed the environment right now. But my question is what happens post-COVID? Because the regulatory barriers that we've heard earlier today they're big barriers, and they have to be changed at the state level here in Texas, and that doesn't happen overnight. That can take years. And then for the regulatory bodies to actually implement them can even take longer. So I'm really curious to see, how does this turn out, in the next 3 years?
Heavy hitting question there. And Michael, let's go to you.
Cari, did you want me to answer that? No. Thanks everybody.
You can predict it.
Thanks everybody for allowing the opportunity for us to be here. By way of background, my name is Michael Farrell, like Natalie said, the Chief Revenue Officer of MDLIVE. If you don't know, MDLIVE is a leading virtual care company, one of the largest in the country. We've been around since really 2009, and we offer virtual care services from a primary care perspective, urgent care, behavioral health, dermatology. We work with about 50 million Americans that have access today to MDLIVE, either through their employer or through their health plan. But we also sell our technology in a white labeled fashion to hospitals and health systems around the country for them to be able to leverage virtual care. I would say similar to my colleagues, Patrick and Cari, virtual care shifted overnight. I've been in MDLIVE for about 3 years, and we've been working with all of our clients and plans and partners to collaborate and to invest more in digital health and virtual care. And overnight, it transformed the industry. So what I've learned is the industry can move mountains, and doctors will adopt this because they were forced to overnight. And I believe truly we're in a new way of healthcare and how it's delivered through telehealth. Because for all the individuals and consumers and patients who have experienced telehealth, the majority of them, from our research, they don't want to risk contagion, so they would do it again. And we're seeing upticks all over the board. So look forward to the discussion, and hopefully that wasn't too long of an intro, Natalie. Back to you.
No, you guys are good at jumping right into things. So, I mean, in the vein of all of that, I think we have, of course, seen this massive uptick in utilization, and so many more clinicians and patients have experience with telehealth. And of course, as we think about the post-COVID world and what the regulatory barriers are, and the payment policies, one of the big questions in that giant question is, what is the impact on total cost of care? And it's a big perspective from the health plan side just to grapple with this. So there are a lot of open questions that we've looked at about what that can mean. I mean, you've got open the door to more unnecessary care. You've also got the door open for better management and better relationships with patients and continuity of care. So curious, we'll start with Cari, but anybody else feel free to jump in too. What is the evidence we've seen so far towards the impact on total cost of care?
Right. I think we don't have a great clear picture yet on this. I know that we're gathering data and that the plans are trying to get a handle on this because it is going to drive future policy. My one question that I have in my mind is telehealth a cost driver or a cost reducer? And I think it can be both. And I think it can depend on a lot of different factors. So are we talking about if we measure telehealth by a particular provider or specialty type or in a particular geographic region? What I can tell you is that when we are working with our customers, they're asking us to measure telehealth at the network and provider level. And what they're really looking for is they want to look at referral patterns. They want to look at the provider quality data across all the specialties, outcomes and ratings, efficiency data, the volume of procedures, readmission rates, and then finally, of course, patient satisfaction. So, but again, as I said earlier, until we see permanent legislative changes, it's going to be hard to know, is it a cost driver or a cost reducer? And so I think there's a couple things of why I say that, and I don't think anyone would disagree that utilization right now is up because it's easy to do. There are no barriers. You can get your prescription. You can see your primary care physician easily if you want to. You can use MDLIVE and you can call, and it's quick and easy and fast. But if those barriers aren't permanently removed, we're not necessarily going to be able to do that. And if it goes back at all to how it used to be, I think you guys know this. If you did telehealth before COVID, it was helpful. But my experience was, I want the prescription, I want the whole thing. I don't want it to go back in and pay another copay because my telehealth provider cannot prescribe medication or needs to see me in person because they can't confirm whatever I have over video. So I think this question's going to play itself out. So that's my thoughts. We're just going to have to wait to see.
You brought up an interesting point around the metrics and the measures and how we are evaluating this. And I think that is a really interesting place for plans, especially to be focusing. The push is for broader reimbursement writ large, right, from the health plans. And as you said, right now we have that. And so that's why we're seeing it. What does the future look like? And I think plans have a really interesting opportunity right now to write some of those rules for what are the metrics they need to see and what is the data that they need to collect in order to prove the case one way or the other, and incentivize and align the industry around the telehealth future that we want to see collectively. I don't know if anybody else has thoughts on the total cost of care more broadly, but I'd especially be interested on what are the things that you are finding are useful measures for determining what does good, successful telehealth implementation look like?
Sure, this is Michael. I'm happy to take a stab. I agree with Cari. It will be interesting to see, where legislation goes and what, the release of restrictions that we've had since COVID has been a value to the industry, but hopefully, the government can continue those forward. So I agree with that. I would say from our plan perspective, our plans are looking at the total cost of care. They're looking at, the redirection of, if they have a member that would have gone into their primary care practice or their urgent care or their emergency department for the sniffle, the cold, the flu, what is the savings they're now driving from a plan perspective on them leveraging virtual and telehealth. We've seen a few of our large plans, national plans that have done studies over this, and it's not MDLIVE, specific, or these are MDLIVE specific, but they're all over the industry, where they looked at segments of populations that use telehealth, similar demographics, all the stats and data, compared them against another demographic who didn't use telehealth over a period of time. And one of our large plans found over that 2-year period that they saw a 16% total lower medical costs for the plan with those 20,000 members that leverage telehealth against the other. And what they also realized was that they had a 37% better adherence to generic drugs. And they also had a 97.6 patient case closure rate compared to that other population. So better use of generics, lower total cost, and a less frequent return for the same type of issue. So I think there are stats out there, and I definitely believe that, I'm in the industry. I see a lot of the value for the cost reducer side of the equation, Cari, but we still get, challenges all over about it adding costs as well. But I think what we'll see, Natalie, to sum it up, is much more data and analytics in the industry from our plans and employers, and looking at the value, really the value of the investment. It's not really an ROI, it's a VOI. And I think that's what the majority of our clients are looking for. So I don't know, Patrick, if you have any thoughts, but those are mine. And, so I'll say one more thing. It's all the referrals, the generic drugs, and the preferred labs and diagnostics are another area that plans are looking to lower total cost. And that's kind of what MDLIVE has been, moving towards from a primary care perspective.
Those are all really, really great points. I think what's so important when we talk about value is, I think there's one component, which is segregation of patient populations. And I think there's higher risk populations where, frankly, we were just trying to make sure that they were getting care. And there was a lot of, things preventing us from giving care to high risk patients, right? And so were they having their CHF evaluated and treated? Is their diabetes getting out of control if they're not seeing their provider? Those are really real concerns, during the pandemic especially. But when we talk about value, now patients have trust in a way of getting delivery. And I don't think we can kind of, short sight that in terms of the ability for us as healthcare providers to engage patients in a new way and help them get generic medications. It's much easier to say, hey, it's time for that colonoscopy. Let's make sure you get that, and engage them in this unique way instead of forcing a patient to come to the office in this kind of old model. So this really is the way that we can practice in the future, and it opens up a lot of excitement. And we won't capture that value until we see these longer term effects.
Mm-hmm. You all have used the word value, which I think comes back to the payment crux of the issue here, which is that we are operating in the fee-for-service model largely. And I think, Michael, all of the cost savings that you're talking about are very often coming from an outside party like MDLIVE, providing services that aren't being provided to patients right now, and working with segments that need that type of care or can serve as an alternative. And that total cost of care accrues to the health plan and accrues to that outside partner. How do you all think about reconciling that with the local provider network, right? And I think that comes back to the incorporation in the entire network adequacy situation, Cari, that you were talking about. But is this simply a question of, telehealth is just one piece of the greater shift to value, and that is the problem that we have to solve? Or are there opportunities for some alignment along the way, just knowing that markets are moving at different paces and payers are moving at different paces and providers are moving at different paces?
I would say it's definitely, a stair-step approach. Yes, payers, providers, it depends from a regional perspective where you're at. There's always going to be a collaboration between the brick and mortar providers, the in-network providers, to the plans, to telehealth providers. And it's really about jointly coming together and really driving down costs together, whether that's, through value-based arrangements. But to your point, Natalie, I think the value-based care model and approach is where everyone's going, and that's kind of the holy grail. It will be it'll be challenging, but I do believe the industry will get there overall. There's definitely innovators and movers who are more ahead of the curve in terms of plans and in-network providers and ACOs. And then there's laggards in the industry as well. I think you're going to see it all across the board, really transpire over the next 14, 18 months.
Cari, maybe you want to add anything on, on that front. There's a lot of, regulatory changes that need to happen to make this possible, especially when we think about, agreeing on what is clinically appropriate use of telehealth. We've got licensing, scope of practice, network adequacy that you've alluded to. What are the big changes that need to happen, and what do plans need to be either preparing for or doing in the meantime?
We've been talking about this. There's definitely a lot of things that need to change. So right now, telehealth is a great enhancer, but we still need to have access to in-person providers, right? And no matter how patients receive care, we need to ensure it's appropriate and it's of high quality. And I think that there are barriers that need to be removed. Some of them were talked about earlier, and I couldn't agree more with the policy analyst that was on the 2 calls ago, and he talked about provider licensure barriers in Texas specifically is a problem. So Texas is not part of the Interstate Medical Licensure Compact, but there was legislation introduced last session, and maybe it's going to be introduced this next session. But licensure, and allowing physicians to provide services across state lines is certainly going to help, especially in rural areas, right? The thing on the network adequacy, so CMS allowed for the Medicare Advantage plans and the telehealth credit, right? And so the telehealth credit basically says that, let me give you an example. If 90% of your Medicare Advantage enrollees need to have a primary care physician within 30 miles, 30 minutes. And with the telehealth credit for primary care, because it is for certain specialties, and that's one of them, you can take a 10% credit. So you can drop that to 80%. And what that means is for 20% of your members, they can fall outside of the 30% or the 30 miles, 30 minutes, with the thought that they're going to be able to maybe receive that care via telehealth. And that would be true if the flexibilities happen, so, and that telehealth appointment just doesn't drive them in to see the physician in person. So that's one thing on the network adequacy. I do see there are a number of plans who have asked for that same flexibility in the Medicaid programs, and I wouldn't be surprised if this also happens here in Texas. I would say if there's any Texas regulators on this call, that might be something that should be looked at over time to see how this plays out in Medicare Advantage, to make sure that it doesn't become an access issue, right? Because it could, if the flexibility is in the telehealth isn't quite meeting all the requirements. But the last thing I wanted to say is quality of the physician data. So CMS later this year is going to issue quality metrics at the physician level for the first time ever. And so I think plans are going to want to start incorporating that data into their network adequacy and into their network management to see exactly what is the quality and satisfaction of their provider networks?
Yeah, that bigger question of having the broad provider network that can manage the patients, and how do we get the right patients to the right providers for the right reasons, the right modalities, the right time, all of those, the list of right. That is a broader question. And Michael, you talked a little bit about, plans, providers, vendors need to partner together on all of this and on this evolution towards a more valued implementation.
Yep.
How do we think about making sure that we are getting patients to those right sources in the right situations, especially as we're getting, Cari talked about more data on the network and the individual providers more broadly?
Yeah, no, great question, Natalie. I could just tell you from MDLIVE's perspective, and we only filter out about 4.5% to 5% of patients that come in. So it's about education. You have to educate your consumers. The plans have to educate their members on what is telehealth specific and what is a telehealth appropriate type of consult. And then there's technology in place, whether that's on the front end, but it's to be able to redirect the patient or the member if necessary. So I think a lot of the national telehealth companies out there, and even a lot of the health systems out there that are leveraging technology are doing a good job, not a great job, of being able to direct the patients where the appropriate level of care needs to take place. When you look at morphing into really virtual primary care, which is where a lot of the industry is moving now, especially since the pandemic, it's about partnering with those local providers because you're collaborating with them on their patient population, and there's still opportunities to be able to refer back in to that network and into that brick and mortar location. But it's really around access and being able to provide the right level of care at the right time. Maybe that individual doesn't need to go to the doctor for, like I talked about, pink eye or a rash or poison ivy. They could leverage the virtual care component, but if there's multiple chronic conditions and they need to be seen for a complex visit, it likely makes sense to coordinate that care to be able to be seen in person by that PCP. So long-winded answer, but I believe the industry is moving towards, continuing to move towards putting that member and patient in the right location at the right time. And that involves collaboration and technology from my perspective.
Yeah, the virtual primary care products are something that, we've seen kind of exponential growth in over the last few months, and I think is a really interesting frontier to explore. And there's so many different flavors of it, and some of them involve, the health system, and it's an anchored kind of joint venture product. Some of them are very focused on those AI chatbots as the entry point, and there's some varying levels of gating and incentives for consumers to start with the virtual and then get referred on. And we're sort of just tracking and watching those to see which ones actually take off, which ones actually become popular, because you are certainly sacrificing many things that employers and individuals do like about existing healthcare access. And so there are trade-offs there. And I think there are also strategic questions for the broader, network ecosystem as plans, networking teams are making decisions about who is in the network, how do we incentivize those, how do we structure, our reimbursements and incentives for participating, and then, are we kind of realigning the teams, so to speak? And so I think there's a lot to be in flux over the next couple years, and it'll be really interesting to see what actually pans out, and if there are new alliances that stick in different ways.
Absolutely.
I don't know if anybody else has thoughts on that front. I know it's a really exciting but evolving area.
I think virtual primary care, obviously I'm biased as I'm a primary care provider, but there are just huge benefits to that concept. But along those lines, patient preference is a huge component, right? And so sometimes in the population that you serve, someone, even for a runny nose, wants to come see you face to face in person, and that's just end of story. And you can't make that patient happy, frankly, unless you facilitate that. And they feel kind of turned off essentially by encouraging them to go down the telemedicine route, even if it's more efficient. So that's a challenge of that provider space day to day, is that even though it makes sense and sometimes from an algorithm standpoint that a patient gets triaged appropriately to to telemedicine, folks still prefer that in-person visit. However, I do I do believe that one of the catalysts for change is that this pandemic has opened people's eyes up to the beauty of being able to get something addressed quickly.
And certainly coordinated with other aspects. Yeah.
Definitely.
Patrick, I'd love to hear a little bit more on, just the clinician perspective and workflow front. I know as we've been having conversations at my organization around the different barriers, those that have been removed and those that are still present, workflow integration is certainly one that a lot of clinicians, I think, struggle with, because it is not seamless right now, the way that we are sort of forcing telehealth platforms on them and into their day-to-day. And I think as we scale up more in-person care in the future, that is something that physicians have to grapple with. And those of us who are trying to support the implementation need to figure out the solutions there. So I'd love to hear just a little bit more about, what are those big workflow challenges for clinicians these days, and what are you seeing as ways that plans, vendors, other organizations can be helpful for them?
Sure. So my background's always been in kind of value-based delivery models, right? Risk-bearing, and so the alignment with the health plan and the system is key, right? And especially when you're caring for complex patients, everyone's goals are essentially the same. And how do we take the best care of this patient in the most appropriate fashion possible? And so, I think that telehealth in this setting allows us to answer that question. It says, is this appropriate for us? And in your day-to-day, if you're presented with a patient with a certain challenge, can I appropriately manage that issue via telehealth platform? And I think that's the challenge that every provider is grappling with day to day. It's like, am I going to miss something? Everyone's afraid of missing and giving someone inappropriate advice, right? And so, fortunately, some patients self-select, but better data, better utilization of this platform, better integration with systems, giving doctors time outside of their normal workflow to be available for this, I think are important components to being able to capture value from telehealth.
The time piece is really interesting. And I think we are operating off of legacy cost structures, right? There's the ideas of the different facilities that we have in place, the different staffing structures, and more nimble organizations or organizations that are in a different payment model can adapt in a different way and make decisions that are all oriented around value. And we are asking this entire provider ecosystem to, instantly transform without giving them an option for what they do with all those facilities and all that staff. That is a high capital, long-term cost that they can't instantly overnight just shut off. And so I think there's a lot to grapple with there, both on the cost side, but also the actual logistics of it and whose job is what in the day-to-day. Michael, I know you've had a lot of experience with just helping providers with implementation of these platforms. Curious for your thoughts here too.
Yeah. So before I spent 3 years at MDLIVE, I spent nearly 13 years at Cerner Corporation, automating workflows and providers, EMRs. So what we've seen in the industry is, the providers had to switch their practices overnight to be able to offer telehealth. And what I found as challenging is continuing to work with them to keep it in their workflow and in their electronic health record, and not having to send a link from a multiple system, but being able to keep them in their workflow and their patients in their own EMR, I think has been vitally important. We've seen some of these small, quick technologies come up now that are more prevalent. Some health systems have moved to Teams, they've moved to Zoom, they've gone with like a Doxy or Doximity, and these providers are doing everything they can just to be able to send a link to a patient in a simple and easy fashion. And that's why some of these, video technology platforms have become so prevalent over the last 6 months, is because they need everything in their workflow and they need it in their EMR. And that's where they have the continuity of the record and the data for the patient and all the information. So anytime the industry tries to grapple on with that or add on technology and take them out of their swim lane, it's not the most advantageous to providers out there. So as being a technology provider, and we're continuing to integrate into their EMRs, and that's what I would say is keep providers in their workflow and make it as simple and easy for them to be able to leverage telehealth, and you'll see wide range of adoption.
Yeah, I've heard a lot of providers asking for, APIs to allow them to do sort of the white labeling thing rather than having to go with the pure out of the box branded solution. So it's a lot of interesting dynamics there.
Yeah.
And, the other piece of that is, of course, the massive proliferation of e-health information, right? We've already seen, I used to know the statistics on all the different terabytes and exabytes and different ways we have to quantify the amount of data that we're producing, but it is really shocking how much is getting generated every day. And all data that some providers need for this idea of continuity of care and managing longitudinally, and with patients seeing so many different types of providers in different ways, all the more need to coordinate that. For all three of you, what are the things that we can be doing to make sure that information is getting into the right hands and used appropriately?
Well, I could start and just say that, from a network management perspective, we do see that one of the most basic and fundamental areas that we're seeing a lot of issues with is just the provider information. So if it's going to be flowing back and forth and it's inaccurate, that's your first problem, and probably the one that needs to be solved right off the bat. Is we need to make sure that we got it for Dr. Vinck. We've got the right information for him, and that's been proven to be way more challenging than I think any payer would have ever imagined. But it is the foundation for the rest of the EHR system to work. Is if you don't have that right, and you don't even have email addresses right, and you don't have locations correct, I mean, I can tell you what we see in data is inflated networks. This isn't you, Dr. Vinck, but I might see a doctor at potentially seeing patients at 40 locations. That's probably not the case. I mean, you're probably really good, but that might be hard to do. So, I mean, I think the first thing is to start at that basic level, and I can't even imagine the challenges of getting the rest of the data interoperable and working. If this has been this hard in just the provider data, I don't know what you guys.
The publicly available, not HIPAA protected provider data. Yes, provider directory accuracy is the bane of many plans.
The pain of many plans that's our daily lives, is helping them try to figure that out.
Yeah, Patrick, Michael, I don't know if you guys have thoughts on the, getting to the more complicated patient data that's coming out of all of this.
Go ahead, Dr. Vinck.
Yeah, I love this question because I think there's so many great components to it. One is the right data getting to the right providers for this patient is just an immense challenge, right? The amount of time our nation spends with staff trying to get information from one office to another via fax and all these other ways is, I would be shocked if it was less than tens of billions of dollars a year just in time spent on faxes trying to get information from one person to another. And so there is a huge opportunity for us to begin to figure out ways to better clinically integrate this data. And of course, the provider's inaccurate information is the bane of most offices trying to figure out even where to send a referral because the information's wrong. On the positive side of this, in the future, that's telehealth. How do we better integrate non-clinical data, right? So the providers want actionable information right in front of them in real time all the time, and they don't want anything else. And that's going to take a lot of time. But then our activity data from our cell phones, all types of this kind of extraneous information. How do we leverage technology? That's actually useful health data. And so in the future, when we're talking about managing a population, we're going to have access to this other stuff that's going to be helpful. We have to figure out ways to use that in an exciting way to help people achieve health as opposed to address their acute need.
Very good points. There's some national HIEs out there like Care Quality, Commonwealth Health Alliance. I think more and more of the industry is moving towards some of those national HIEs, and technology companies like myself and even the large EHRs out there are a part of those and trying to continue to move the needle forward from an interoperability perspective. There's still a lot of ways to go, but I know a lot of our plans lately have been wanting us to ingest data on the individual members to be able to present that to our providers face first if they come in for any type of consultation. And that's something we've done for select plans around the country, but it remains a challenge. It's the #1 interoperability challenge out there from a data and a continuity perspective for providers. So I believe the industry is moving in the right direction. It's not nearly as fast as what we all would like.
Yeah. We got a question in from the line along these lines around, are there any EHR workflow assessment plans in place? And I think they mean, are there ways of evaluating, how well this fits into a workflow from an interoperability and EHR perspective? What are the characteristics that plans should be looking for and providers should be looking for in these solutions?
Well, I could take a stab at that. I mean, we're at MDLIVE, we have our own EMR, that all of our 2,400 doctors, they leverage today for technology and for being able to do telehealth visits. And it's all about, accuracy of data. It's about the quality of the patient, the time it takes in the documentation, the ease of use, like the automation tools that you build into your electronic health record, whether that's ingesting patient information on the front end from the intake process, so then the provider gets a suggested automatically diagnosis, ICD-10 code, they get suggested medications, prescriptions, patient education material. So it's all about making the providers as efficient as possible from our standpoint to be able to offer extremely high quality care virtually. So we're tracking a lot of those various metrics, and it's the same from the EMR world I came at, the number of clicks that the providers have to go through for their documentation. Can they bring in things like voice technology or drag in nuance to be able to dictate? So it's a lot of the same type of information that I found we were looking at in electronic health records when I was with that company. Dr. Vinck, what do you think?
I think those are great points. The amount of time providers spend on documentation is a huge issue, and these exciting AI drag-in and other types of platforms. Imagine speaking to a patient on the phone or via telehealth platform, and that communication is dictated into a note as opposed to, the doctor having to go afterwards and type those things up. I think we can all question the value of certain documentation, and so how do we leverage technology to improve that quality and extract great data out of it? That's an exciting area.
Now, we've talked a lot about the clinician experience and the provider experience. I want to turn to the ever important patient experience, which also has its fraught perils as there's multiple sign-on points and a lot of confusion, especially with patients that haven't used this kind of technology before adopting it. Because we have such a wider range of patients using this, what have you all learned in recent months about what's important for patient experience and what things we can prioritize on improving? And Dr. Vinck, I'll start with you as the resident primary care physician who's actually been doing a lot of this live with patients right now.
I think patient experience is just vitally important, right? And so I think we're all American consumers at the end of the day, and our patients expect similar type care to what they get at kind of these high functioning systems like Starbucks, right? And so our patients expect that, and I think that crosses all socioeconomic boundaries, and so that's important, I think, for clinicians and health groups to embrace. Because it's becoming more and more important, right? We're all watching NPS scores and ensuring that patients are enjoying the experience with our groups. So that's vitally important. It also relates to an ongoing collaborative relationship with patients, right? And so all this technology we talk about, all these things that we talk about, is so that we can make patients have the trust in the system that they're going to have the outcomes that they're looking for. And so that's what all this conversation is about at the end of the day, is that the patients get better, the patients are, trust the plan to follow through with. And if we do these things right, it's seamless. It's a huge effort on the back end, but the patients engage the system and better outcomes are the result.
I would add on. I would agree. It's all around the frictionless consumer experience, though, on the front end. Dr. Vinck is absolutely right. I mean, we track NPS, down to the nth detail. We A/B test everything for these consumers that come in. We do not want them, like our providers, having to fill out 15 pieces of information just to get registered into MDLIVE. If they're part of a health system or part of a health plan, that health system or health plan wants to be the single face of digital health for their member. They want that digital front door. So it's about us as technology providers creating that seamless experience where they go to health plan A, they sign in on that portal. If they need a virtual visit, it seamlessly single signs on them into our platform and our technology, so they don't have to add new data points and refill out information. So again, it's all around that consumer mind front of just providing the best frictionless experience and the highest quality of care.
Mm-hmm. Now we're all talking about the Starbucks experience, the Amazon, Apple experience. The other side of this, of course, is the digital divide. And I think we've seen, especially recently, across the board, the ability to access these services is not equitable. We have really big concerns about broadband access. Many patients, if you have limited data plans, you don't want to spend that precious data on a conversation with a care manager for some examples. So, there's preferences around which modalities patients use that relate back to access to, just public resources in general. What is the responsibility of all of our organizations here in taking action here? And does that need to get factored into maybe some of the payments as we think about, mitigating some of this digital divide and unequitable care? Cari, I don't know if you have perspective there.
Yeah, well, I can tell you that our payer customers are asking us to look at the social determinants of health alongside their network data. So, for example, we can overlay the population demographics in a particular network so that the payer has a pretty good idea of, okay, we are gonna maybe have an issue here with your members being able, to purchase cellular data plans. So, where are they going to go to get their telehealth? Are they going to be, going to the free Wi-Fi at the local fast food restaurant? Or, how's that actually going to work? So when we overlay that data, we're able to see, really interesting data points that really tell us about where it makes sense, where if the rural broadband is there, and I'll be honest with you, from my experience, I live in sort of a rural area. If I drive 20 miles outside of my area, I have no cell phone reception. And so all I can do is text. And so I think that, having that data about the network of the members in the network is going to be really important, so that the payers can make good decisions on, how should they be delivering the care, and what extra things are they going to need to provide for their members to access care via telehealth.
Mm-hmm. Yeah, it gets us into the territory of many of the social needs interventions that the payers and providers and others are dealing with. And you have this collective action issue of whose job is it to fund it? How do we coordinate all together on something that is traditionally outside of the healthcare realm, but very much impacts everything we're doing and trying to accomplish. So I know we are approaching the end. This went by very, very quickly. So thank you all for a spirited discussion. I'm going to give everybody an opportunity to just share one big piece of advice for plan leaders as they try to further integrate and promote telehealth services. So Michael, I'll start with you, put you on the spot since I introduced you last.
I would just say continue to invest in telehealth. The studies that our other plan partners have shown so far are that it is lowering the total cost of care. There are best practices out there that I'm sure your providers and your technology partners will work with you on. $0 copay is one of those, and they've or cost share. And we've seen a tremendous uptick in that, and plans wanting to continue on with that in the post-COVID world. So continue to invest in telehealth, and the value of investment we are seeing as ever increasing, and that's probably about it. I can hand it over to my colleagues, and they can give some advice.
Cari?
I would say track your data, track your data, track your providers, make sure that they are how are they accepting telehealth? You're going to have to go out and survey and ask them, right? And you're going to need to pull that information into so the consumer's aware. Is it just audio? Is it audio visual? What's the capability of the provider? So that information is going to have to be brought in, and then definitely start measuring your social determinants and your utilization and everything else to make sure that you're building the future network for telehealth.
And Dr. Vinck, we will let you have the last word here.
I'll try and integrate both the last two questions. The CDC and New England Journal put out some great information about how older patients who are often non-English speaking on Medicare and Medicaid saw a lower proportion of telehealth visits during the pandemic. If we solve that problem, it'll help all of us, and it'll help lower costs, and it'll also help us solve the challenges associated with telehealth. So I think if we focus on that group, we can make a huge impact.
Well, we are at time. Thank you all so much for this. This is a great discussion. And I think this is a really good way to end, because the next association forum is scheduled for the 20th of October, and it's going to focus on how plans are addressing social determinants of health. So it should be a really nice segue there. Hope everyone has a great rest of your day, and thank you so much for joining us.
Thank you, Natalie. Thank you, Dr. Vinck. Michael.
Thanks, Micah.